Fantastic. Let's get started. We have the pleasure of having Dr. Kevin Billingsley, our Smilow CMO, today to start us off and welcome everyone.
I am thrilled to be here, and I want to thank the audience for not just participating in this event, but for the participation over the months in this series of Smilow Shares. The partnership and collaboration between clinical oncologists and primary care physicians is not only fun and rewarding, it's the best possible thing for all of our patients together. So I have to say I'm incredibly excited about the topic this evening. The statistics in 2022 are that there are currently over 18 million cancer survivors out there in the United States today. I think it's extraordinarily gratifying. I think it's a testament to the development and our abilities to treat patients and sustain them through the course of their illness. But it is also a testament to our medical community in general, particularly our primary care physicians who support patients and families through the continuum of healthcare throughout their lifetime, including supporting them through significant illness like cancer, heart disease, and other chronic diseases that they manage them in partnership with specialists. So I think we have a fabulous panel this evening. I'm just going to say I'm incredibly excited. I think it's going to be a great discussion. And I want to also take a minute to recognize and thank our fearless co-leaders in this program, Dr. Ann Chang, who's the Associate Cancer Center Director here at the Yale Cancer Center and our Director of Clinical Initiatives, and Dr. Karen Brown, who's the Medical Director of Primary Care for Northeast Medical Group. Thank you both for really leading this effort and driving this level of communication and engagement between the primary care docs and our oncologists. So terrific. And I know you guys will introduce our panelists. So over to you, Ann and Karen.
Thank you, Kevin. This is our last program for the year that Karen and I have been working on, and this really came out of discussions that we had where we felt that there could be a better relationship and better communication about cancer and updates, but really from the primary care perspective. I see some of you have been regulars, and we really appreciate you coming and appreciate your feedback on this, since we're talking about what to do next year and how to. So any feedback would be.
And your audio just got quiet.
Okay, can you hear me okay?
Yeah.
Okay, sorry about that. So we're going to have 3 cases tonight, and then we will have time, about 10 or 15 minutes, hopefully for questions. And I know that you all have really great questions, and I think that the presentation, the cases tonight will really prompt that. We'll have questions for Dr. Sanft around survivorship after the first case, and then the rest of the questions. So please have a few questions ready, and then we'll have time for the rest of the questions later. And then without further ado, I will introduce Dr. Tara Sanft, who's an associate professor of medicine, and she's our chief patient experience officer in Smilow, and the medical director of the Survivorship Clinic. She is, Dr. Sanft earned her medical degree from the Medical College of Wisconsin. She completed her residency and fellowship at Northwestern. She is board certified in both medical oncology and hospice and palliative medicine, which she feels helps her to treat the whole person and not just the disease. And as a breast oncologist, she has a very busy practice and enjoys taking care of women with newly diagnosed breast cancer. And in her role as the chief patient experience officer, she focuses on how to improve care, especially where the provider and patient experience overlap. She is the director of our Smilow Survivorship Clinic, one of the nation's only multidisciplinary clinics specializing in cancer survivorship. And she learns from patients about key issues after treatment, which also informs her role as chair of the National Comprehensive Cancer Network Survivorship Guidelines. And finally, her research interests focus on healthy lifestyles and quality of life after cancer. And we welcome her tonight. Dr. Lustberg is an associate professor of medical oncology and the director and chief of the breast medical oncology division. She received her medical degree from the University of Maryland, where she completed her residency, and she went on to complete a fellowship in medical oncology and breast medical oncology at the Ohio State University before joining the faculty there in 2010. And she also earned a master's in public health from the Ohio State University in 2013. She's been recognized for her patient-focused care with awards, multiple awards, and including being rated by Forbes as one of the top breast medical oncologists in the nation. She has an emphasis on improving long-term outcomes for patients with breast cancer who develop side effects associated with treatments, and is doing novel and really exciting research on novel blood-based biomarkers to identify recurrence and toxicity of treatment earlier. She's an NCI-funded investigator and active in cancer cooperative group research, and she collaborates widely with researchers from around the world, and she really thrives in creating innovative multidisciplinary scientific teams. I'm going to turn that over to Dr. Brown to introduce Dr. Williams.
Good, thanks. And I'll just echo my welcome to everybody as well, and to stress how important all of this is. Our relationship in primary care. New cancer is kind of an emergency. And knowing that our Smilow team kind of has our backs and is able to help with that transition is really important. And we continue to work at doing that even better. And even though this talk is about kind of the other end, where we're passing patients back to primary care. So it is my pleasure to introduce Dr. Brian Williams, a close colleague and friend. He is the medical director of clinical informatics within the Northeast Medical Group and one of the medical information officers for Epic in the system. His passion is streamlining clinical care to support both employee and clinician wellness, as well as patient experience and efficiency. He is an active primary care clinician in Mystic, and where he serves with his wife in the same office. He's fortunate to serve as a medical director in the beginning of his career at the it's a health center in Hawaii from 2005 till 2010. And that was where he learned from a visionary leadership team where integrating the electronic medical record and clinical quality programs had such potential to make patient care better. He subsequently came here east and was the medical director of informatics at the L&M medical group through 2016, when that group merged with Northeast Medical Group, and he then became part of our informatics and clinical program. He graduated from the University of Colorado Health Science Center and completed his family medicine residency at University of Texas in Austin, Texas. And Brian will actually start off the presentation with case.
Thank you, Dr. Brown. I'm so sorry to throw you the curveball. It's Hamakua Health Center.
Thank you for the correction.
Absolutely. Yeah, that's a tough one, but a beautiful place. And I'm really pleased to have been asked to participate in this particular topic. I think this, survivorship sits squarely at the intersection of what our colleagues in oncology do and what we do in primary care. And I think this is an area where More information is better. It's frequently, I think, a little bit vague in terms of concrete information that's available for us to kind of guide our decision making and care. So I'm really looking forward to this session. So we're going to kick it off with case one, which is a 76-year-old male that had a 60-pack year smoking history, who presented in June of 2019 with complaints of increased difficulty swallowing. He was having a hard time getting food down. He was subsequently diagnosed with a squamous cell carcinoma that affected the left side of the base of his tongue. So during July and August of that year, he received definitive conformal radiation therapy with concurrent weekly cisplatin. He tolerated treatment quite well and had complete response to the tumor, fortunately. So since that time, he's been followed every 6 months by his oncologist, and there's been no evidence of recurrence, but he missed his last follow-up appointment and in fact would rather not ever have to see a doctor again in his life. He has some residual long-term effects of treatment, including dry mouth and chronic neck stiffness, but overall doing well with no evidence of disease at the present. Go on to the next slide. So he presents today for his annual wellness visit to his primary care. No ongoing concerns other than the usual aches and pains and the continued stable neck stiffness. He is stoic though. This guy spends all of his time out on his fishing boat and in his garage working. He doesn't like doctors and he doesn't want to see anyone he doesn't have to. So the questions associated with this case are, first of all, what is survivorship? So I'm going to openly admit that this was a concept that was new to me approaching this webinar. And so I'm really glad that we're sharing about this because it's something that I found to be quite important. Second question, follow-up, is what kind of surveillance guidelines are there for high-risk patients in general, and maybe a little bit of specifics about this particular patient, since this is a high-risk cancer. And then a final question we're going to answer is, what is the Smilow Survivorship Clinic, and which patients are appropriate for referral to this clinic? With that, I'll turn it over to Dr. Sanft.
Thanks, Brian. Coming off of 5 days of conferencing in Chicago, so forgive my hoarse voice. Really pleased to be here with all of you tonight, and I see many familiar names on the participants list, so a shout out to my friends in the audience. But if we start with the definition, the NCI defines a cancer survivor as anyone who's been diagnosed with cancer, and it starts at the time of diagnosis and extends through the balance of the individual's life. In that context, every patient who's ever been diagnosed with cancer is considered a survivor. And if you go to the next slide, there are 3 phases of survivorship, which I like to just briefly touch on. This was defined by a physician who had cancer and then wrote this article in the New England Journal in 1985. And he characterized these 3 phases as acute, extended, and permanent, but I renamed permanent to long-term. The acute phase is really in that first diagnostic period, probably, Karen, like when you said this is an emergency, like that is when you're going over the waterfall, you've just been diagnosed, there's lots of tests and imaging, and you see an oncologist and surgeons and radiation doctors, and you're going to have a treatment plan, and you're in treatment. And the whole cancer community, a lot of times your whole support community comes together to carry you through this time. If you click through the animations here, the next period is the extended period, which should be highlighted, and then another click to show the picture. I love this picture. I don't know if it's real, but you know, the extended period starts after treatment is over. So usually treatment's about maybe 6 months. If you get chemotherapy, maybe a little less. If it's not, maybe you might be on some maintenance therapy for the whole year. But generally, in that after that 6 months of really heavy going over the waterfall, the waters are calmer, but you're pretty sure, the patients are pretty sure something is going to get them. Every ache and pain is a recurrence. They might be dealing with their side effects. They might have a lot of post-traumatic stress type symptoms. So they feel like it's a high uncertainty. And that's where our clinic often comes in. And I'm going to talk about that in a few minutes. If you click through the next animations. One more click. So in long-term survivorship, this is when the waters are much more peaceful. The risk of recurrence goes down, but the late and long-term effects serve as a reminder of what you've been through. And so for each of these phases, survivors can have different needs. And I think that's, one of the reasons why it can be so hard to wrap our minds around survivorship as a field, because it really encompasses so much time. Next slide, please. There are certain themes that tie every single survivor together. So we can unify each unique person, and they have a common set of needs that need to be met. And this is simplification, but we all agree that every survivor needs surveillance for both recurrence and a new cancer. And in general, at least in that first extended period, the oncologists want to be doing that kind of surveillance, and patients want their oncologists to be doing that kind of surveillance. As time goes on, that surveillance might get less frequent, less necessary, and the needs of those survivors might change on who needs to do that. And then every survivor needs identification and treatment of late and long-term effects. And we can talk about incidents of all of that and different risks that would cause that. But we are all charged with identifying and addressing those. And then the topic of health promotion is what I personally is near and dear to my heart, because there's very few times in an adult life where you're willing to change your behavior, and cancer is often one of those. And so really using that teachable moment to help patients meet their goals for their diet, their exercise, maybe not drinking as much as they used to, smoking cessation, especially in head and neck cancer patients, as we know, can be so important. Every patient, but those are tenets of survivorship care for everyone. And then, of course, why we're here is that we owe it to our patients to coordinate this care, make sure that nothing is falling through the cracks, which is so much easier said than done. Next slide, please. I was going to plug in this gentleman's profile on an app that I thought was available and show you like how we would solve this together if you didn't have a survivorship clinic. And I don't know what happened to the app. I couldn't find it. So in head and neck cancer patients, for instance, if you Google survivorship, and the American Cancer Society is a wonderful resource for both doctors and patients, you're going to get a PDF of guidelines. And if you even click on the link that says, a simple chart, this is one page on the left-hand side of a 3-page chart. This is for head and neck cancer survivors. There's also the same information for breast cancer survivors, colon cancer survivors, prostate cancer survivors. And that's kind of where ACH, that's like ACS, the American Cancer Society, that's where their guidelines are sort of fitting. So instead, I just summarized sort of what is in this document on the right-hand side. So again, it's a 3-page table. You'll see that there are recommendations for surveillance, screening, and early detection of second primary cancers. They really call that out here because that's a particularly high risk in the head and neck cancer world because of the treatment that's given and the risk factors that are often associated with it. Then assessment of management of physical and psychosocial long-term and late effects. I listed those down there at the bottom. And then, of course, health promotion and care coordination. If you look at the list of late and long-term effects and you read the chart, every single one recommends that you, primary care, screen for each of these things, detect, and refer. And I feel overwhelmed just reading through that chart and can't imagine what it's like in a busy primary care clinic to maybe have that sense of duty to try to detect and treat and refer for specialized treatment for all of these issues. So I just, curious on any comments on that, but this is what's in the literature right now. Next slide, please. There is also, you can find this on the American Cancer Society website. There is a link to this cancer survivorship e-learning series, and there is a 1-hour webinar that focuses on head and neck cancer survivorship. What I was hoping to show was how you could figure all of this out in a few minutes, and it really, I think, illustrates the fact that this is hard. I don't know how many people have an hour in a preparation for a patient to go and watch this to learn more about addressing this particular patient's needs. Next slide, please. So I'm ending with just 2 slides about the Yale Survivorship Clinic. We have been around longer than I've been at Yale. So it was started by a cancer survivor in 2006. He explicitly said, "This is what I wished I had had in my cancer treatment. So this is the team you must assemble if you want my money." And so Yale said, okay. We serve patients of all diagnoses. Any patient who's had a diagnosis of cancer is welcome to come to our clinic. And we meet once weekly, and we go to the different various Greater New Haven locations. So we see patients in Smilow, but we also go to Guilford, North Haven, and Derby starting next month. Just a minute, I'm on a call. Sorry, I also have a couple kids hanging around. We give, just a minute, honey. Okay, all right, I'll help you. Amelia, can you help her get some food? We see patients for a one-time consultation, and then we usually have 1 or 2 follow-up visits. So we do not assume care of our patients, but they do get a 2-hour visit each time with 4 specialists, and I'll tell you about them in just a minute. I think it's important to understand we do not take the place of either the oncologist or the primary care provider. But we do meet the patient where they are at, and we provide a lot of individualized counseling and references based on what the survivor is hoping to achieve. And every single patient gets an individualized survivorship care plan. Next slide, please. Okay, so who's the team? So I'm the medical director. I do see patients, but really the bulk of the patients are seen by my fabulous physician's assistant, Kevin Bretta, who would have loved to have been here tonight, but he's actually on a vacation and we want him to enjoy that. He's the PA there in the top left, and he's the one who makes those survivorship care plans. He's the one who's making sure patients aren't lost in transition, that they understand, what the plan is going forward, who's going to be doing what, and he addresses late and long-term effects from a medical perspective. The LCSW licensed clinical social worker is next to that. Right now it's Kristen Clark. Our social workers have the highest level of training in their field for cancer, and they really talk about the psychosocial aspects of coping with cancer. And so, for instance, back to this case, many of our head and neck cancer patients, though this man is stoic, he may be having some fear of eating. Could be that he's doing less socially because he's afraid of choking in public because of his chronic dry mouth. So this would be an example of what the social worker might talk about and try to plug him in with some help to cope with that and to validate those feelings and maybe even treat anxiety and depression. Our physical therapist is actually also the head of our onc rehab program, Scott Capozza, and he actually wrote the board questions for the ACSM oncology certification for physical therapists. So he's been doing this for a very long time, and he helps patients either get back to the physical functioning that they had before, or maybe start a new plan to help meet new goals. And then, of course, as a PT, he would be able to assess for this gentleman, his range of motion, his ability to stretch his neck. He would be able to prescribe a home exercise program to help with any symptoms that he's having in his affected fields. And then our last provider is a registered dietitian who's also a certified specialist in oncology. So again, the highest levels of their field in cancer care And right now we have a new dietitian named Natalie Smith, and they really address, not only weight gain and weight loss. So in this particular gentleman, probably he's lost some weight through his treatment, and possibly gaining that weight back can be really challenging. And lots of well-intentioned family members may have told him that all these supplements that he needs to take to prevent recurrence, and our dietitian really addresses myths about nutrition and cancer, of which there are many, because the diet industry is a billion-dollar industry. I forget if there's one more slide. That's it. So we would be happy to see any patient that you felt could benefit from what I just described. It doesn't matter if they're within that year, or maybe they're 3 years. And sometimes we've even gotten patients who are 10 years out. And we also try to face our patients. Every year June is Cancer Survivorship Month. And we try to go directly to patients with webinars just like this to address issues. And this will be our 4th June that's virtual, and it starts tomorrow. And I'll just say that you can find this on our website if you yourself are curious, or if you wanted to send a patient. They're going to be every Wednesday in June from 6:30 to 8. Tomorrow we start with a panel talking about restoring your body to integrity after cancer. And on June 14th, living with cancer chronically. On June 21st, cancer and the family, how to advocate for your loved one. And on June 28th, myths and social media. So thank you very much for your time. Oh, thank you. And yeah, I'll stop there.
We do have time for a few questions, a couple of questions for Dr. Sanft. And you can put them in the chat, or you can actually, I think you have to put them through the chat actually, or the Q&A.
So Dr. Sanft, I'm going to just ask a quick question. Is there space for those of us in primary care to communicate with you offline, just in terms of recommendations around particular patient cases?
Absolutely. We would love to consult on any questions or issues that are coming through, or even listen and help find the answers if we are not immediately got them on the nose. Because of what we do know where to find these answers probably quicker than a Google search, and certainly quicker than the time you have to try to look and figure it out. So, my email is tara.sanft@yale.edu. Jevin Britta is my PA, and this is his full-time job outside of helping with some of the breast patients that we see together. But this is where we spend all of our time. We'd be happy to consult offline and then help plug patients in as needed.
Yeah, I really truly appreciate that. And in primary care, we're, I think, frequently overwhelmed with the number of recommendations and items that we have to pay attention to, and all of the things we have to juggle with patients. And knowing that we can kind of lean on you as colleagues is very helpful. To me, I think that the two big takeaways for this case are, first, that patients with certain cancers are at much higher risk for other cancers. And actually, I've also learned that frequently their rate of appropriate screening is lower than the general population, which is surprising, but I think something for us all to keep in mind. And the second thing is that there are great resources in place to help guide kind of care decisions for these patients.
I'm curious the way, Dr. Williams, you set this up is this gentleman really didn't want any more follow-up, even though, he probably needed ongoing surveillance, at least from primary care and maybe also from oncology or ENT. Would a trip to the survivorship clinic kind of been something that would help him to understand why, or help him kind of come to closure on this? How would it have worked in this particular case?
So given that this is a real patient that I know quite well, there's not a prayer that he would ever go. He's
Okay.
a lovely gentleman, but he's let's just say that he's a tried and true New Englander, a little rough around the edges. In this case, access for me to some of these survivorship resources is going to be very beneficial because I can help guide him, and we sort of have that ongoing connection, even though he's never all that fond of even seeing me. But that's in this particular instance, that's a very helpful thing. I think other cases, definitely your suggestion that might help give him the context to think about this going down the road, it would be very beneficial.
Can I just quickly comment on that? There's, we see men and women, probably about 300 per year total. So there's lots of people that don't make it into us for whatever reason. They either don't know or they don't want to, or they don't think they need us. Oftentimes for men, wives bring them or children bring them. And really, it is kind of a little bit against their will in some ways. The reason why we have 4 specialists there, including a social worker, and you see every single one, is to really give that space that, yeah, you would never have agreed to see a social worker and talk about how you're coping with cancer. But when it's built in, it's shocking how therapeutic it can be and how much people say, I didn't know that how much I really needed that. So,
Right.
so I appreciate all those points.
One more question from Jill Banatowski.
Yeah.
And that is, the role of community PT versus this specific PT. Is there kind of handoff? Is there something special about it?
Yes and yes. So the cancer onc rehab is a specialized field, and our patients really do. Many of them do need someone who understands you don't want somebody who's going to be manipulating something that's not right and then cause more harm. Thankfully, though, many of the PTs in Connecticut are extremely reputable and experienced, and local physical therapy is fine. What we do is we first try to get Scott to see the patient in clinic, and then he knows all of these providers, and he'll say, oh, in your area, this person, she's even lymphedema specialized, so she could even assess you for head and neck lymphedema, for instance. And, oftentimes he'll even make the connection through email or something like that. So yes and yes, local is fine. And a rehab specialist can be really helpful to get the ball rolling, and especially ours who maintain relationships with people all over the state.
Fantastic. Thank you, Tara, so much. And I know you have a family commitment to get to. So thanks for joining us. And we'll move to the second case here. Thanks again.
Right.
And
Case 2 is one that'll be close to many of our hearts. So it's a 71-year-old female with medical history significant only for hypertension, which is well controlled, and hyperlipidemia. She was diagnosed at age 62 with right-sided breast cancer that was an invasive ductal carcinoma. It was grade 1, anatomic stage 1A, estrogen and progesterone receptor positive, HER2/neu negative. So she was treated with a right mastectomy and a subsequent prophylactic left-sided mastectomy and bilateral reconstruction. She continues to be followed by oncology annually and has been maintained on anastrozole without any evidence of recurrence. She's very active. She stays healthy, takes care of herself, exercises daily, good diet. Then we'll go on to the next slide. So she presented with subacute onset of localized mid-lumbar back pain. Her pain was localized to the L2-3 region of the mid-back. She described it as an ache with a maximum intensity of 4 out of 10. Gets worse when she's exercising and walking. It troubles her a little bit in bed as well. There's no other symptoms associated with this and no bowel or bladder complaints. Her physical exam was largely unremarkable. She's not tender in the area where she localizes her pain, and her neurologic exam was non-revealing. So the questions we might ask in this case include, how do we approach new complaints that may be related to cancer, may be harbingers of recurrence? And specifically in this situation, how common is recurrence in breast cancer?
Thank you, Brian, for overview of that case. Hi, everyone. Thank you for joining out of your busy evening. As you heard, I've been treating breast cancer patients for a number of years, and very thrilled to be speaking with you. So the question is, how often do recurrences happen in breast cancer? And we tend to see two peaks of recurrences, where we have an early peak of recurrences that can happen in the first 3 to 5 years. In this particular case, if you remember, she's in her 9th year, and she has this hormone receptor positive breast cancer. Late recurrences can happen sometimes more than 5 years or sometimes decades from the initial diagnosis, and these are more common in hormone receptor positive breast cancers, where they're more favorable, but they also tend to have this period of dormancy where even if all the right treatments have been done, patients have done all the right things, we could see recurrences that happen years down the road. So next, to the next slide. And press one more time for this. Yes. So just kind of giving you a little bit more about how common these late recurrences are. They're very much proportionate to the initial risk of the disease. In the yellow line, you see lymph node negative breast cancer, which was this particular patient's case. And as you can see, 5 years, even up to 10 years, the rate of death from breast cancer can be quite low. However, as time passes, a proportion of these patients can actually progress to metastatic breast cancer, which is the predominant way that individuals from breast cancer actually die from breast cancer. It's not from early stage disease, it's from metastatic breast cancer. In the blue and red lines, you can see how patients who have higher stages of disease, lymph node positive disease, then the curves are very steeply rising. For example, half of the patients who had a number of lymph node positive disease, this would fall into the stage 3 category, can potentially recur sometimes several decades after initial diagnosis. So when we see those media campaigns saying breast cancer, if caught early, is a curable disease, it absolutely is. But a lot of those SEER statistics and American Cancer Society statistics are geared toward these first 5 years. However, what our data are not showing is what can happen several decades later. So it can be actually quite hard for patients, because the campaign has been, just do what you're told, get your mammogram, get your treatments, and this is curable and treatable. And when these recurrences happen, it can be extremely psychologically traumatic. So next slide. So this patient, had some back pain. This is your bread and butter. You see, I'm sure, multiple patients during the day present with back pain. And in no way are we suggesting that just because she has this distant history of breast cancer, that you necessarily deviate from your standard algorithmic workup and your good clinical judgment of having taken care of patients for many years. But just I think the point of this case is that this history of breast cancer, even though it's almost 9 years, does raise the suspicion that it could possibly be related to metastatic breast cancer, and to at least have that on the differential. And an unexplained pain that doesn't go away. So let's say you do all your good primary care workup and conservative measures, and she's not improving. I think what we would like to avoid for patients with, for example, this type of history is to perhaps raise that index of suspicion a little sooner, so that they would get a little bit of a closer workup sooner than a patient, let's say, without a history of breast cancer. So pain is one of the most common presentation of these types of distant recurrences. I tell my patients, as a human, you are going to have aches and pains. You're going to have back pain. You're going to have shoulder pain and knee pain. Not every sign of pain is a sign of cancer. But if something is persisting and not responding to these conservative measures, then these patients should be absolutely worked up more. Shortness of breath and cough are also another more common presentation, where again, people are going to cough. But if it's just not going away and lingering, that raises the suspicion that something more should be done. A vague abdominal pain can sometimes be one of the initial presentation of liver metastases and breast cancer. And in the red box is this very general description that I also share with my patient, which is that any symptom that you're worried about that cannot be easily explained, I think we want to at least have our index of suspicion up. Next. And you know, it's this partnership, that the theme that we've been focusing on, and we're so grateful that you're here so we can have this conversation. Patients often feel very lost in these junctures where they kind of don't know who to turn to. And as much as we can do to show that we're partners, that we are, I think it can be so helpful in terms of the anxiety, and I apologize, in a public setting. Sorry for the background. So to just the idea of this, that we are a triad together, working together to expedite the workup. These are the things that are really, really important to patients. Next slide. And so just re-emphasizing that this is a super vulnerable time. There are often a feeling of betrayal. There can be even some anger toward the original oncologist that diagnosed them, because we celebrated that they're cured with them. There's a sense of, why wasn't this found earlier? I went to my PCP and I complained about this 2 months ago. Why wasn't this worked up? So these are not that anybody did anything wrong, but I think it's that time of vulnerability for these patients. Obviously, healthcare systems are very complicated, and it takes time to schedule testing. We completely understand that. But just all of us being really cognizant that given how high the anxiety state is for these patients when they're worried about potential recurrence, anything we can do to even move things up by a day or two really goes a long way in terms of rebuilding trust within the healthcare system and making them feel heard. And the last point I've already said, but it's really important to repeat it, which is the more we communicate with one another as primary care providers and oncologists, it is so absolutely reassuring to patients. So in this particular case, it may have been a bread and butter musculoskeletal back pain, or maybe something else. But bone metastases are actually the most common presentation of hormone receptor positive breast cancer metastases. So we wanted to kind of highlight that as one of the more common presentations of metastases for this group.
Thank you, Dr. Lustberg, and thanks for joining from the airport. I know that that's really over and above. It's one other note that I just wanted to make about this particular case is, you know, this patient really took to heart the recommendations around self-care. She, you know, at the time of her diagnosis, she really, let's just say, made some very appropriate and long-lasting lifestyle adjustments, and those do impact like longer-term risk of recurrence and also risk of other health conditions and other primary cancers. So case 3, this is lung cancer and a video visit, an 85-year-old female without significant past medical history that was diagnosed in 2019 with a non-small cell adenocarcinoma of the right lung that was metastatic to her brain. So she was enrolled in a clinical trial in November of that year with pembrolizumab plus bevacizumab for asymptomatic brain metastases. 4 cycles of the combination followed by pembrolizumab monotherapy. She completed a total of 34 cycles every 3 weeks, which was tolerated quite well and responded very well. And she's been followed by oncology since that time without evidence of recurrence and still remains in good health. Go to the next slide. So she presents today for a video visit complaining of nausea and vomiting for 5 days. She's been having a hard time keeping food down. She tested herself at home and was positive for COVID. So she continues to have nausea currently and is able to keep sips of water down, but she's not complaining of any other symptoms relatable to the COVID, such as congestion, cough, shortness of breath. She does feel achy all over and chilled, but no fever. Her physical exam, limited of course by the video visit, but she appears mildly ill, but not emergently ill. She's alert and oriented and answers all of our questions appropriately. She doesn't appear to be short of breath, speaking in complete sentences, and there's no cough noted during her visit. Her mucous membrane, she sticks out her tongue, and her tongue is moist, so that's good news. So a few questions related to this case. How do we monitor patients that are very high risk for recurrence? And how do we approach patients with an acute illness that have a higher risk of complications of that illness? And then finally, what other options are there for patients to address survivorship in general?
Thank you, Brian. So this case was selected to really highlight a few important points, which is that advances in cancer treatment, particularly immunotherapy, have dramatically improved survivorship outcomes in patients with lung cancer as well as melanoma. So now we're seeing long-term survivors of these very serious malignancies who are doing well, but they may have some complications related to the original cancer diagnosis or to their treatment. So patients who are higher risk and have known metastatic disease, typically, depending on the type of malignancy, they are routinely followed with serial scans. And so in this particular case, patient had a known brain metastasis, her brain would be serially monitored and her body would be monitored. In other malignancies, other types of surveillance modalities may be used, such as bone scans and or PET scans. So you're going to see in your practice patients being surveillanced differently based on their type of cancer and where they are in their disease course. In terms of symptoms, so often these patients with more advanced illness may get additional scans based on the new symptoms. So, for example, a breast patient who may not be normally getting brain MRIs, if she's suddenly reporting a headache, that may necessitate additional imaging. Patient preference partially weighs in terms of our surveillance. Some patients really are extremely anxious about scans, and if they've been stable for a very long time with advanced disease, we may actually lower the frequency of the scans. And then there are some patients who are very reassured on scans, or if they're on a clinical trial, that may necessitate additional scan frequency. Next. Is it moving forward? And so with our newer treatments, a lot of these patients with more advanced disease, and re-emphasizing the point made by Dr. Sanft, is that the definition of a survivor does not exclude patients with more advanced illness. So they're all survivors from day one of diagnosis throughout the balance of their life. But they may be on ongoing treatment, and the checkpoint inhibitors, which are the predominant immunotherapy class that we're using in a range of malignancies, can have many types of immune-related toxicities, and they may present to your primary care office with symptoms that you'll be kind of wondering, is this an immune-related toxicity, or is it a common, just a regular old symptom that may be unrelated? So these are the challenges that we all face. Is it related to cancer? Is it related to cancer treatment, or is it something else? There's also a range of oral targeted therapies that are now actively being used. So patient can essentially take a pill therapy that is specifically targeting a protein or antigen on their tumor. And again, impressive results in terms of treatment efficacy, but they can have a range of side effects, including fatigue, rash, metabolic issues. So this is what we need your help with. So if they're developing hyperglycemia in these agents, for example, we absolutely need your partnership to better manage these. Next. And so there's lots of resources in terms of toxicity management, and I think this may be a separate webinar if there's interest on this. But one thing I've highlighted, because you will be seeing a lot of immunotherapy complications in your practice, is that the American Society of Clinical Oncology guidelines for immunotherapy are readily available, and it's a really good, solid resource. Also, don't be afraid to reach out to us. Again, we're not asking you guys to be immunotherapy experts, but to just have that index of suspicion of if these patients are on targeted therapies or immunotherapy agents, that some of the things that may seem routine may actually be related to the cancer treatment. Next. And then this was a really important article that really launched an expansion of how we see survivorship, which is that patients with metastatic cancer, again, it fits the NCI definition, but for a long time, as a community, we have sort of felt that, oh, it's only for patients with curable disease, which is absolutely false. And so Tom Smith and Terry Longbaum wrote this really wonderful article that was published in 2019 in the New England Journal of Medicine, really highlighting a lot of the similarities and differences that can happen in the related to survivorship related concerns in patients who are in remission, kind of in that extended or long-term phase that you saw Dr. Sanft talking about, or patients who are actually living with cancer. And as you can see, there could be physical issues, emotional issues, sexual health issues. There's actually more similarities than differences in terms of some of the domains of survivorship. So, so this is an area that we would love to partner with you to help support these patients. They're actively being seen in both primary care as well as oncology offices. And all of the survivorship resources that we've been talking about are available for these patients as well. Next. And so kind of coming back to those patients with who have had incredible responses to immunotherapy, there is now a body of literature really talking about the experience of how these patients actually feel after essentially being told that, you know, you have advanced illness, we're not sure how long you have to live. And then because of the advent of immunotherapy, they're actually living years and years after diagnosis. So there's a body of work developing in terms of this particular study showed that they feel like they live in a twilight zone. They feel like they're between the edge of death and the living, and they're not quite sure where they fit in. So kind of in the coming years, you're going to see more of this type of work coming out, where we're beginning to understand better the needs of these survivors with advanced illness. Next. So I want to make sure we have time for your questions. So just wanted to just highlight a few quick takeaways, which is that patients with advanced cancer, like this particular case, she may have just had COVID, or she may have had COVID plus possibly a recurrence of her cancer. I think it's the differential that we all would think about. Brain metastasis recurrence can also present with nausea, vomiting, and not the malaise and not being able to eat. So just kind of keeping that differential wide is important. Quality of life and symptom management is particularly important in these patients living with advanced illness, and coordination of care with you guys is even more important in these patients with more complicated cancers on ongoing treatment. And as much as we can regularly communicate, the better. So I'll stop there and make sure we have time for some questions. Thank you.
There are no questions from the audience yet, so if you're listening, please enter questions. Dr. Williams, do you have any?
I do have a question. So immunotherapy is a really recent occurrence, and I think many of us in primary care don't have a tremendous number of patients that have actually received immunotherapy, like the ones we discussed. What's the time horizon for us to be alert for potential adverse effects from those treatments? Is it mostly during the treatment window, or is it something that can occur kind of longer, subacute, or even kind of years?
Great question, Dr. Williams. So the majority of these would be first picked up on if that is more of an acute reaction while patients are receiving immunotherapy. Thyroid dysfunction issues, for example, are extremely common. And we actually, if you wonder why is the oncologist checking thyroid function, that's what I do. It's actually part of our chemo plans to actually be checking thyroid function and adrenal function, because these toxicities can be so common. Pneumonitis and cardiac issues are a little less common, but it's something that we, if a patient is presenting with shortness of breath during treatment, or really any type of cardiac issue, the cardiac immune-related toxicity can actually be deadly if it's not picked up early. So you're going to see, if you see your oncologist doing certain types of workup that you're kind of like, well, cardiac workup, it should be something I would be doing. It's related to kind of that high index of suspicion for these immunotherapy toxicities. Rashes are really common with immunotherapy as well as targeted therapies. So that's something that's very commonly seen. And then we also worry a lot about colitis, immune-related diarrhea. Where we typically, if we're worried about it, we would have to hold the immunotherapy, typically start high-dose steroids. And you can imagine if somebody already has metabolic syndrome or diabetes, all the things that you guys are expert at, we can kind of get into those cycle of trouble where we're starting these high-dose steroids and then their blood sugars are spiking, etc. So that's another point where good close communication is super important. But to answer your question, most of the time these toxicities do happen during treatment, but then the endocrinopathies that happen during immunotherapy do not necessarily go away after the immunotherapy is over. So we're sort of, the patients are left to continue to manage those complications.
That's helpful. That's really helpful. So is it safe to say that, should a patient who's actively undergoing immunotherapy present with symptoms that could possibly be really related, it would be important for us to get a hold of the treating oncologist immediately?
Yes. And I think pretty much from head to toe, any organ can be involved in terms of immune-related toxicity. So absolutely, this is exactly, we would want to hear from you, and we are not expecting you to be the sole clinician managing these, but even alerting us that a patient is having trouble. They may have called you before they called us, and I think that's why it's important.
Well, I think we've run out of time. I just wanted to say that last patient was my patient and she's doing well. She just had COVID. So that was good news, but just wanted to again, thank you all for participating this time and throughout the year. Please write something in the survey about it, just because we can get your feedback as we try to figure out what to do next year. And then I'll just hand it over to Karen to close.
Just want to thank everybody for their attendance. Thank the panelists for their preparation and thoughtful approach to these issues. Actually, Anne, I want to thank you because it's the end of our first year doing this. So we will have a little celebration together, which does not mean we won't have recurrence. All right. Good.
Thank you all. Have
Good night, everybody.
Good night.
Thanks, Brian. Thanks, Maryam.